to zoom out a little bit. Oops. Wrong way.
Hi, I'm Dr. Jerry Hesch from the Hesch Institute in Aurora, Colorado. I'm a physical therapist, and my client presents with low back and buttock pain and pain down the posterolateral thigh, and this is her pain drawing. And she's received 3 months worth of pelvic floor physical therapy. She has a sensation of a shard of glass in the rectal area, which is improved somewhat with injections into the sacrotuberous and sacrospinous ligaments. And she has a history of having a side-bent coccyx and of having asymmetry of the pelvis, which the upper pelvis presents as being very symmetrical today, and her mobility of the upper pelvis, of the pelvis, is good in terms of superior and inferior mobility, and in terms of rotational mobility, that is good. And then springing the sacrum, you can even see the heels move when I spring the sacrum, so that mobility translates through the pelvic joints. But the lower pelvis presents as being asymmetrical and not moving, and the crease of her clothing matches the midline crease of the buttocks. And when I palpate medial to the ischial tuberosity, you can see there's a much greater space on the left side. And when I capture the ischial tuberosity and I attempt to spring it to the right, it doesn't move. I can't take up the slack. And the same thing occurs on the right ischial tuberosity. And the same hypomobility. You can see I can take up a little bit of slack in this direction, but once I take up the slack, then I cannot induce any additional mobility. And that's true going right to left through the left ischial tuberosity. And this is a pattern I described, more than a decade ago. And I named it lower windswept pelvis. It's not in the literature on pelvic mechanics or so-called sacroiliac joint dysfunction. And I think this pattern is a global pattern that involves the entire pelvis being twisted about an axis up high, where the symmetry is maintained in the upper pelvis, but much greater in the lower pelvis. And I believe that it also involves the hip joints, and it might involve the sacroiliac joints. It might have an external cause for restricting mobility, translating through it in that direction. There's certainly controversy about the sacroiliac joint. I'm very well aware of that, and this pattern has never been studied with stereophotogrammetry, which is the very standard of looking at joint mobility. So it's based on observation and based on passive spring testing. And it couples with a left side bent coccyx. And when I come and isolate the coccyx here in the midline, and I come on each side and I lift into the sulcus, she's distinctly deeper on the left sulcus. And I'll show you that on an anatomical model. So here is the transverse process of the first coccygeal segment, and if the coccyx is side bent, I think you can appreciate that sulcus would be deeper going vertically on the left side. I hope that makes sense. Okay. The other interesting thing that she presents with that she was unaware of is that she has considerable restriction in terms of internal rotation on her left hip. Now in prone testing, she's about 45 degrees on the right, and she has a soft end feel or normal end feel. And on this side, she actually has pretty free mobility. But if you look at it in a different context, let's have you lie on your back, please. So if we flex the hip in supine and look at internal rotation, she's 45 degrees normal end feel. And on this side, she's almost 45 degrees. But if you look at it in the context of the hip and knees being in neutral, I can roll her right hip to about 60 degrees with a normal end feel. And on this side, she's 10 degrees with a rather hard, rather firm end feel. And I don't know if we're going to change this by balancing the lower pelvis, but we'll certainly find out. So we'll stop filming shortly, and then we'll treat her and we'll film the response to treatment. Thanks.